there, my name is Rossi Grilz, and today I will be presenting on my DNP scholarly project titled Development of a Clinical Practice Guideline for Exercise Recommendations in Oncology Patients. The purpose of this project was to develop a clinical practice guideline that supports oncology providers in safely and confidently recommending exercise to patients undergoing active treatment for cancer. So throughout this presentation, I will review that process with you. This includes looking at the background for the project, the literature review, the methods used to develop the guideline, as well as the results of the appraisal and the implications for clinical practice. So the committee for my project included myself, as well as my DNP chairperson, Dr. Pauline Foy, my second reader, Dr. Jennifer Theo, and my community member, Kira Moore. A little bit of background on the topic. So cancer treatment is notorious for negatively impacting overall quality of life. Some of the possible side effects that we can see from cancer treatment include fatigue, nausea, weakness, and adverse mental health symptoms. Research has supported that exercise can be an effective intervention in mediating some of these side effects and improving overall treatment tolerance. The studies have found that patients who stay active throughout the course of their treatment regimen tend to have overall improved physical, emotional, and psychological well-being. So let's discuss project significance. Even though the benefits of exercise during cancer treatment are well documented, patients often tell us that the topic never comes up during their oncology visits. A 2019 survey of oncology providers found that most oncology providers believe that exercise is beneficial, but few routinely discuss it due to several variables. One of those is a lack of time in their day and in their follow-up visit with patients, and also they have expressed that they have a lack of confidence in how to safely recommend exercise to patients undergoing treatment for cancer. So there is a bit of a gap, and providers have expressed an additional desire to learn more on this topic and how to go about initiating this discussion. In my own experience as an oncology infusion nurse, the clinic I work at, I found that recommendations between providers tend to vary fairly significantly. Some patients will say that the provider has never brought up the importance of staying active during treatment, and others will say, well, one provider told me I need to initiate this level of exercise, and another provider told me I need to do much less or much more. So the purpose of this project, it has several goals. It's hoping to address that gap by improving provider education, and it also serves to create a standardized guideline so those recommendations between providers kind of level out and match between patients and providers. Moving on to a review of the literature review process for this project started with using Ovid's synthesis. This was the primary search engine that I used to conduct my literature search or literature synthesis, and findings from this search found that exercise during cancer treatment provides a wide range of benefits. It tends to improve mental health by reducing symptoms of anxiety and depression, and it also has shown to improve physical functioning, and it enhances overall quality of life. So all of these findings put together support the idea that exercise is a beneficial and healthy intervention that we can recommend to patients who are undergoing active treatment for cancer. Importantly, even small amounts of activity have meaningful benefits. Patients don't need to engage in intensive exercise regimens to see improvement. Many of the studies that were randomized controlled trials assessing the effect of minimal or no exercise to a structured exercise regimen recommended 150 minutes of aerobic activity combined with 2 strength training sessions per week. And this is supported by recommendations from the American Cancer Society. But other studies have found that engaging in minimal activity or leisure time physical activity, so this includes, gardening or brisk walking, cycling, racket sports, things that are not necessarily structured exercise regimens, but still encourage a patient to get out and move. Those tend to be effective as well. So with this helps us see that any amount of activity is better than none. So as providers, we can encourage our patients to engage in the amount of activity that they are comfortable and willing to engage in. And finally, multiple studies highlight that although providers believe in these benefits, they often lack a structured tool or a guideline to help them give safe, consistent exercise recommendations. So this last point helped lay the foundation for this project and set the stage for what this clinical practice guideline would become. As far as theoretical frameworks go, the framework that helped guide this project is Dorothea Orum's self-care deficit theory. The central idea behind this theory is that illness can limit a person's ability to care for themselves, creating what is known as a self-care deficit. Cancer treatment is notorious for doing this because it often negatively impacts energy, strength, and emotional well-being. In Orum's framework, a self-care requisite is something that a person can intentionally do to support their own health. Exercise during cancer treatment is a good idea of a self-care requisite because it's an action that patients can engage in to maintain strength, improve mood, and support overall well-being during treatment. This framework helped to shape the guideline by emphasizing patient empowerment. So we are doing that by empowering providers to help their patients, and engaging in exercise takes, autonomy and motivation from the patient themselves. So by giving these patients clear, safe recommendations to engage in exercise, we're hoping that this will give them a sense of autonomy to feel confident in participating in their own care. As far as methods and design go, this was a non-interventional DNP project, meaning that I did not assess the effectiveness of an intervention. So rather, this project focused around the development and the evaluation of a clinical practice guideline. So the first step in this process, after obtaining the initial approvals from the Maryville University DNP Project Committee and the Maryville University Institutional Review Board, after doing these steps, I conducted a structured literature review, which we kind of discussed in the last slide. But this was to help me understand the current evidence on exercise during cancer treatment. From that review, I identified 4 central themes that helped to form the backbone for my clinical practice guideline. Initial guideline development was a back and forth process with my DNP chairperson, Dr. Pauline Foy, and several revisions were made at this stage to help me get the initial draft of the guideline ready for the review process. So once that first draft was complete, I had 2 oncology providers evaluate the guideline using the AGREE Global Rating Scale. The AGREE Global Rating Scale is essentially an abbreviated version of the AGREE-2 tool. It was developed by the same authors who created the AGREE-2 tool, but it was created in response to user feedback requesting a shorter tool. The AGREE Global Rating Scale allows for the collection of both qualitative and quantitative feedback. So after collecting that data, I did data analysis to see where the guideline could be improved for the final draft, which is the final draft of the guideline that is involved in this project. As far as sample goes, the sample of reviewers for this project included 2 experienced oncology providers. One of those was a board-certified oncologist with over 20 years of experience working in oncology, and the other was a physician assistant with nearly a decade's worth of experience working in oncology. Both are currently active in their profession. They actively counsel patients during treatment, and this made them ideal reviewers for the guideline. The site for which this guideline was developed is a community cancer clinic located in northern Utah. So it was developed with the outpatient setting in mind. For data analysis, so as I mentioned earlier, the AGREE Global Rating Scale allows for the collection of both quantitative and qualitative data. So I analyzed data using both quantitative and qualitative methods. As far as the AGREE Global Rating Scale goes, it is composed of 7 questions that assess various components of a guideline. Scores from the AGREE Global Rating Scale are rated on a scale of 1 to 7, with 7 indicating highest possible guideline quality and 1 indicating lowest possible guideline quality. Each question also allows for written comments, which is where qualitative data is collected. And the AGREE Global Rating Scale, I just want to throw this out there, it does not allow for the calculation of domain scores like that of the AGREE-2 tool. However, studies have supported that scores on each question of the AGREE Global Rating Scale tend to correlate well with domain scores obtained from the AGREE-2 tool. So because domain scores were not calculated, quantitative data analysis for this project involved the use of descriptive statistics. Mean scores for each question on the AGREE Global Rating Scale were calculated, and this helped highlight strengths and areas for improvement within the guideline. Any score that had a mean score less than 7 showed me that there was some variation between reviewers, and that helped me focus where I wanted to improve my efforts on the development of the final draft of the guideline. Qualitative data was then evaluated using thematic analysis. So I looked at each comment from reviewers and tried to identify common themes to see where I could improve my guideline for my final draft. As far as results go, for the quantitative results, the mean scores for all 7 agreed GRS items ranged from 6 to 7, which demonstrates high overall guideline quality. This means that across both reviewers, each domain of the guideline was consistently rated as strong or very strong. The highest mean scores were in areas regarding clarity, purpose, and overall usefulness in clinical practice. And even the lower scoring items still fell in a higher score range, indicating that there were no major weaknesses of the guideline. There were just areas for improvement. However, mean scores of less than 7, as I mentioned earlier, those indicated aspects of the guideline that could be improved with future revision. For the qualitative feedback, the main suggestions for reviewers were to embed reference tools directly into the guideline. So within my clinical practice guideline, I encourage oncology providers to assess a baseline level of activity using a scale called the Godin Leisure Time Exercise Questionnaire. And both providers just said it would be helpful to have that tool readily available within the guideline so they didn't have to go find that on their own time. So this was recommended to make the guideline more usable in clinical practice. And I just want to point out the table here. So this showed the differences in scores between reviewers. So you can kind of see where that variation occurred. And this was helpful, especially in combination with the qualitative findings from the thematic analysis. It really provided me with an extremely clear avenue for improvement so I could make my final draft of the guideline more applicable to clinical practice. As far as limitations go, so one limitation was the use of the AGREE Global Rating Scale instead of the full AGREE-2 instrument. The AGREE Global Rating Scale, I selected that initially because this project, I had initially intended to complete a separate DNP project, and as far as timeline went, I didn't have time to successfully finish that. So I changed course, and so this project was completed on a fairly restricted timeline. And when I was obtaining initial approvals, I decided that the AGREE Global Rating Scale would be more appropriate given the limited time and resources. But this is considered a limitation because it doesn't allow for the calculation of full domain scores in the way that the AGREE-2 instrument does. It also hasn't gone the same extensive level of validation testing. So while studies have shown that yes, these scores tend to correlate well with domain scores, it has not undergone the same level of extensive validation and reliability testing as the AGREE-2 instrument. So while it does provide a good overall quality rating, it gives less detailed information than I would have obtained if I'd used the AGREE-2 instrument. Another limitation was the limited number of appraisers. Only 2 oncology providers evaluated the guideline, and this meets the minimum requirement for that of the AGREE Global Rating Scale, but a larger group may have offered a wider range of perspectives and reduced potential bias because the providers that I used are specialized in oncology. This is what they do every single day, so it's quite possible that they were familiar with this topic before reading the guideline. It might have been beneficial to see perspectives from other providers who do not specialize in oncology. And that leads right into the third limitation. This was the lack of evaluation from other disciplines. In addition to including other providers who do not specialize in oncology, other disciplines that might have offered beneficial insight include oncology nurses, physical therapists, or other specialized who counsel oncology patients on activity. Their feedback could have strengthened the applicability of the guideline. In the review process, I found areas where this could be improved for oncology providers, and that was an insight that I didn't have until the guideline had undergone that appraisal process. So it could be said that having other disciplines review the guideline would help me understand other areas where the guideline could maybe be improved for future use. And the final limitation I wanted to discuss is the lack of generalizability. The guideline focuses on adult patients with cancer, and some of the supporting studies involved single cancer types. I really tried to include a variety of cancer diagnoses in the guideline itself from the studies that I'd identified, but some of them focused on breast cancer. Another one focused solely on high-grade glioma. So future studies could perhaps be improved by finding a wider age range as well as a wider range of diagnoses. And this would make the guideline more generalized for all patients with cancer. So in the discussion, I really tried to focus on what the appraisal results actually mean for the guideline. The average Agree Global Rating Scale scores range from 6 to 7, which shows that that initial draft of the guideline that underwent evaluation and appraisal was already of high quality. It was clearly written. Providers expressed that it had appropriate clarity and it underwent the appropriate methodologic rigor, but it still provided an opportunity for improvement because ideally I'd love those scores to be perfect across the board. So it helped me understand where I could improve the guideline in my final revision and final draft. The qualitative comments were also really helpful in this process. I discussed this a little bit earlier, but both reviewers shared that the guideline could have been more user-friendly and more applicable to clinical practice if the reference tools were embedded directly into the guideline. So on that final draft, I embedded any referenced tools as appendices so providers could quickly review those and have them available at a glance. And that feedback was crucial. It was instrumental in helping me determine how I could improve this for future use and how I could make it truly applicable to clinical practice and available for real-world use. One aspect of the guideline that I was particularly proud of, both providers expressed that the guideline is very well aligned with current evidence, which is what I was hoping to achieve. So that was one factor that I was quite proud of. So what are the implications for practice? These implications focus on how the guideline can support oncology care moving forward. First, I want to mention that the guideline supports safe and consistent exercise counseling. It provides oncology providers with a simple, clear structure that they can implement so patients are no longer getting mixed messages about physical activity during treatment. One aspect that I do want to mention about the guideline is that it also provides providers with a certain level of flexibility. So if they're seeing a patient that they're worried about recommending the 150 minutes of aerobic activity with 2 sessions of strength training per week, it encourages providers to recommend the level of exercise that they're comfortable with this patient engaging in. And this goes back to that point where we talked about on the review of the literature that some activity is better than none. Leisure time physical activity still provides benefits compared to the structured exercise regimens that patients can engage in. So by helping providers make these recommendations, I am hoping that we will help patients. It is, in my mind, supposed to be something of a ripple effect or a trickle-down effect. If I am helping providers recommend exercise to their patients, I'm hoping this will result in improved patient quality of life, because if they're exposed to this information in a way that they're comfortable with and that their providers are comfortable discussing, then hopefully they'll take these findings and run with them, and they'll notice improved quality of life, improved overall well-being, and improved treatment tolerance. Another point that I'd like to touch on as far as implications for practice go is that this guideline enhances evidence-based oncology care. It brings current research together in a practical format that helps clinicians to ensure their exercise counseling is grounded in the best available evidence. And finally, I do want to touch on opportunities for future research. Future research could evaluate how the guideline is implemented. This would involve seeing how providers use it in practice. Do they feel it could be improved when they're actually using it? And how do patients respond to these recommendations? Do the recommendations in the guideline truly enhance patient activity levels? Does it improve their quality of life? Does it improve their emotional well-being, their physical fitness? That is something that could be interesting to pursue in future research opportunities. As far as conclusion goes, so the purpose of this project was to create and evaluate an evidence-based guideline that helps providers feel more confident recommending exercise during cancer treatment. The Agree Global Rating Scale results were consistently high across all items, showing that the guideline is clear, it's well supported by the literature, and it's clinically relevant. Altogether, the findings from this project show that this is a strong, usable guideline that can realistically support oncology providers in practice. I also want to mention that this project helped me develop a sense of resilience that I truly did not know I was capable of. It pushed me to grow in so many ways, both personally and professionally, and I learned how to translate evidence into something meaningful for real world patient care, which was a goal that I'd hoped to achieve from the onset of even just the discussion of engaging in a DNP project. So for that, I will be forever grateful. And these are the references I used. I broke them up into 2 slides. So here's the first slide, and here's the second slide. Thank you so much for watching, and I hope you have a wonderful rest of your day.